My nostrils clear?
They're good. You look sharp.
We're good.
So we're online and we are here at EFIC Day 3, somewhat across midday, and it's about that time where we just had a plenary from our next guest here in the studio. My name is Dr. Morten Høgh, and in the studio with me.
Why is that funny?
Because I'm not really, it doesn't say on my certificate, doctor. I'm just so proud of the work I did, because it was quite a struggle, wasn't it? So it's new to me, so I'm just using it everywhere.
Good.
Tossing it all around.
Throw it out there.
Probably take it out at some point, but right now I'm Dr. Morten.
Excellent.
And in the studio here with me, I've written something down that I think really encapsulates who you are. You are a snake-bitten, truck driving, soccer treating, bullet dodging, clinical scientist with different socks.
Nice.
Professor Lorimer Moseley.
G'day.
G'day.
G'day. G'day.
You from Australia?
Oh, clearly, yes.
Yeah, and you've sort of been around the block, haven't you?
Gee, it makes me sound really rough and old, and I feel like I'm still going around the block.
Yeah. So in terms of academic career, you were trained to begin with before you were a physiotherapist, you've done loads of different stuff. But was physiotherapy your first sort of encounter with treatment, injuries, that sort of thing?
Yeah, well, not my first encounter with injuries. I mean, I did a physiotherapy degree in pain because of a back injury. So I certainly feel like that exposure was very much the lived experience of what it's like to have pain and be in a healthcare system and probably have interventions you shouldn't have had and stuff like that. But physio was certainly the first place that I was acting as a health professional trying to help others in pain.
And when I said you've been around the block, it's basically because you've been in the game for quite some time, and I'm pretty sure that most of the people tuning in now will be familiar with who you are. And one of the anecdotes that I have around you is that you were almost ready to quit physiotherapy, and then you had sort of an enlightenment.
Yeah.
Do you remember the story I'm referring to?
Well, I presume this is the story. Well, there's a couple of moments where I've felt like that, but this may be the story where I came across David Butler, and I was enrolled to start another course at university, and primarily feeling like the strength of desire I had to help people primarily in persistent pain, because they seem to be the outcasts and the oppressed in our healthcare system. They're almost universally distrusted, called malingerers when they're clearly not malingering, and I didn't have any real skills to help them, except for I was finding that giving them understanding seemed to be the most effective thing I was doing. And I thought, as a physiotherapist, that presents a challenge. And then I was on a surfing trip and went into a conference, I think mainly to claim a tax deduction. And there was a fellow in his bright green glasses and talking emphatically about, as physiotherapists, we should go beyond the foramen magnum into the skull, so beyond the spinal cord into the skull. And I thought it was so inspiring. And at the end of his talk, I think I went, "All right," and started clapping, and I was the only one clapping. He was like a heretic. And and then he came down and thanked me for my support, and that's when I met Dave. And I think that was a moment where I thought, maybe I should keep going on this. Maybe there's a better way to do it.
Yeah. And I want to stick to people you've met who probably shaped your career to some extent, because there's another person who's already a professor as well. He's in the same field, so he's a physiotherapist by background. But I think by the place we stand today, he's a complete different figure. So it would be Professor Paul Hodges, isn't he?
Yeah.
How did you get about doing your work with him?
Oh yeah, I enjoy the contrast you paint between Paul Hodges and David Butler, and very different people, both people I hold in very high regard, very different shapes, more like the body shape is so different, I used to.
I think we should also say they're not the same age either.
No, that's correct. They are not.
I think one
the
of
same
them would be
age.
heavy that we mention that.
Yeah, probably. I used to call Paul Hodges the walking cortex because he's got this mind like a steel trap, never forgets anything. But then he started running. So I have to call him the running cortex. So I came across Paul as a PhD student. I was in my first year PhD at the University of Sydney, and my supervisory panel worked with me to say, well, in your clinical practice, what's the thing that you'd most like to understand better? And the role of transversus abdominis and multifidus, so these muscles, one around the trunk, one in the back.
Oh, they still do, I think.
They're still, what do you mean?
They still run around the trunk.
Yeah, no, yes. I'm just explaining to the people who might not be familiar with transversus. Okay. It's the corset muscle. And Paul, so I was very interested in this clinically and really wasn't having any joy clinically with these treatments that were meant to be really current and contemporary. And I went to Paul. I asked Paul if he would meet with me, and I said something along the lines of, I don't think this is causing the problem. Can you teach me how to do science and understand that? And I will be grateful forever that he did not do the logical thing, which would probably be, get out of my sight, you idiot. But he was really gracious and said, yeah, I'll help you do that. And I was his first PhD student, and a real privilege to learn science under Paul. And he and I have had different perspectives on pain that are becoming more aligned, I think, over the years. But he has always advocated for me, to my knowledge. He's certainly been very patient with my skill set, which is just way short of his. And I have the phrase, I think I wrote in my PhD acknowledgements, that somehow Paul took me, Paul helped me become a scientist against all my natural tendencies otherwise. And I'm really grateful for that, yeah.
And just before we go on, there's a third person I think has also, from my perspective, informed who you are as a clinician. Michael Nicholas, Professor Michael Nicholas, is that true?
Yeah, Mike. So Michael was my first PhD supervisor. So he and Paul were my PhD supervisors, and I had a lot of help from a physiologist called Simon Gandevia, an absolute beacon in the motor control world. But I met Michael because he was the dude in the world that seemed to know the most about self-efficacy. And again, I asked him,
so
will you be my supervisor?
Wrong, but Michael Nicholas was a person who also took care of the multidisciplinary pain treatment centre at St Thomas's Hospital in London.
Yeah, so he kicked off St Thomas's, and when I met him, he was running ADAPT out of Royal North Shore Hospital.
And I noticed when you just gave your plenary lecture here at the European Pain Congress in Valencia that your list of acknowledgements is so long, and I noticed that David Butler was on top of that list, and just below him a dear friend that we both know, Professor Mike Thacker, was there as well.
Yeah.
What has been your professional relationship with Mick in terms of the neuroscience? So Mick, I think people would know Mick. He's a really clinical neuroscientist as well. He's done some wet work with animals and stuff.
Yeah.
And how does that correlate with what you're doing?
Well, I connected with Mick actually at my first ever World Congress, and he was doing his PhD under Patrick Wall, Steve McMahon, who I think you've spent time with here. You know, these absolute legends of, I mean, you're talking about influential people. Patrick Wall was a very big influence on me for very, very short interactions that I had with him. But Mick struck me as someone who, I think about all these people you're talking about, and I tend to have a habit of being really attracted towards people who are just way more clever and capable than I am, I think. And Mick is a remarkable thinker. and he's a humanist. And I think we met professionally, but I think what we shared professionally were values that are deeply integrated with what we do, and it's the values we connected on. And then the conversations we have. So Mick's work in immunology. I mean, he was part of the very first investigations of how does the immune system have a role in chronic pain. I mean, in his PhD and early postdoc work, he was proposing things that now are up at plenaries. And one of the things I love about him is that he's lived by values. He hasn't lived in the pursuit of some corruption of those values, and I really love that about Mick. But from a professional perspective, what I learned from him is that I don't always make a lot of sense, and he reminds me of that. Like I mentioned in there, I said one of the target concepts that is integral to Pain Revolution, which is this community outreach pain science thing. A lot of research with consumers, hundreds of consumers giving us feedback on what's the most important concepts. These are consumers who have recovered. We say, so what was important for you in your recovery? And we identify these target concepts, and one of them I put up in my plenary was the brain produces pain. And I know that if Mick was in the audience, he would have been resisting the opportunity to shout out some expletive to say that's not true. It's not a brain that produces it, it's a human that experiences it. And I think that he would be more accurate than me, but he and I have different lines on where we're prepared to, I guess, accept semantics, if you like.
Yeah.
So yeah, answer to your question, Mick makes me think harder and keeps me accountable, I reckon.
That's good. And the reason I bring this up, all these people, I'm sure there's loads more.
Yeah.
Because as you say, you have a massive network, and the way I know you is you're really good at integrating knowledge from different places and doing all of this. And I think this informs at least my understanding of who you are as a person.
Right.
So personally, you're someone who likes to engage with people, and you mentioned Mick being a humanist, and I take it from that you care about humans. That's sort of the basic understanding of humanism, isn't it? Or,
yeah.
Or you can say it's a sort of racism where you prefer humans over other animals.
Yeah, no, that's a really interesting point, and it's off topic for pain, but there's a part of me that I think accepts that I'm humanist, but I cannot justify that position ethically. But then, not much of my life I can justify ethically. I can't justify that I act in my children's interest over someone else's child's interest. So that's unethical. So I sort of embrace this idea that I am a humanist in an evolutionary driven system. So I will protect mine. That's so off topic, sorry. Go. Let's get back on topic.
No, it's fine. So I'm really trying to put this into perspective, because I hope what we're going to do here is discuss different aspects, and by no means they're going to, justify everything, and there will be things that we can't go into. And I know if people were here and they could ask questions, they would ask tons of questions. What we talked about before is trying to take snippets out of things that you are involved in.
Can I just clarify, what's a sniblet?
I don't know.
Is it a snippet?
There might
and
be.
A giblet?
Which one should it be?
Yeah, no, either. I just loved it. I loved that you rolled with it.
And I love you didn't. Well, thank God it's not live. We can just cut it out later.
Yeah, good. Okay.
Yeah. Anyways, we're gonna take stuff that by no means justify everything you are doing,
sure.
and just try and dig down to them. But the essence of it all is that it's sort of what you are doing, all of this.
Yeah.
And we'll try to see if we can connect it by the end of it. I'm going to pick you up on something you said in the plenary to start off. You said if you ever meet someone and they say, I'm a clinical pain scientist, ask them, can you tell me about pain? So, can you tell me about pain?
Let's talk about coming back to bite you. Well, my natural answer to that question would be, well, tell me what you'd like to know.
And why is that a good question?
Oh, it's That's a good question, and why is that a good question? I think that really just speaks to my own presumption that I know my pain, I feel it, I create it, if you like. Not obviously, I don't decide to create it, but it's produced by me as an organism, and I know what it's like. But I don't know yours. And if that question came to me at a barbecue, I think it's highly problematic for me to presume I know what you're asking me about. So I would want to know, well, what would you like to know and why? If I can help answer that, I will. I mean, if the question was, tell me about pain science, or tell me about why you're a pain scientist, or what a pain scientist does, that's a different sort of question.
But that wasn't really the question, was it?
No, it's a really good question, but I think whenever we get asked it, I think it provides us an opportunity to have a relationship with the asker. And I think it's easy as an educator or any sort of expert to presume that question comes from a position of naivety, right? Because we're used to being, I'm the pain scientist, therefore I'm some sort of pain expert. I mean, in this community I'm not, but in the global community, in my mates at football or riding bikes or whatever, I'm the pain guy. It's easy to slip into the illusion that you asking me about, tell me about pain, you're asking me because you don't know. And that's an illusion, right? Because you think how many times you've experienced pain, and if you're asking me, you're either an interested person, or your pain is something that is problematic and is bothersome. So you've probably had a fair bit of it. And I think that we have an opportunity to engage in a relationship that I'm very happy to offer anything I can, but I don't want to presume that I know what you want. And I know more about stuff than you do, I think.
Yeah, and this ties into another thing you said in the plenary, which is that, so you referred to Australian male drivers.
Yeah.
Almost 100% would say they're better than half of them.
Yeah.
Or
better than average.
Yeah. So of course that can't be, but we have this feeling of being different. And you have done studies that suggest that people who are in pain, attending a multidisciplinary pain program, they feel that their pain is of course right because they feel it, and they might have the perception that others' pain is not the same. And is that the case also in your mind with clinicians? So if I was asked, tell me about pain, and I say, well, no, I'll tell you about pain, then I will start telling about my pain, and it might not even be what's relevant for the patient.
Yeah.
Is that?
Yeah, I mean, it's probably important to say, so in that, that data are old data, really old data, and really, when I was asked to do that plenary, there was a sense of, can you give a perspective on the field and the historical underpinnings of the journey and where the field sits now, and I tried to be true to that instruction. But I was gobsmacked, so I was very surprised back then that people would come out of these really good best practice pain programs, having spent the entire program thinking they were there by mistake. That their presence was in error because they've got real pain. And why would you go to a psychological based treatment for a physical problem? Like, clearly someone's made a mistake.
Yeah.
And they go through the whole program thinking, well, everyone here is at a psych program because they don't have real pain, it's all in their head. I don't, because I can feel it. And that really struck me, and the data were so compelling. But if we fast forward to now, I think the question actually still stands. Like, I know we're getting better. The data clearly say that community attitudes are shifting. There's a greater endorsement of persistent pain as a legitimate health problem. Governments are recognising it's costing a lot of money. Healthcare professionals are recognising they don't have the skill sets with just the things that treat the tissues or turn off the transmission system. However, I think there are still a lot of consumers, I even don't feel comfortable with that with that term.
Let's just discuss it. Why would you call it consumers?
Well, I don't like calling people
And
in pain.
in this case would be what some people refer to as patients, or it could be.
Well, I don't feel comfortable with that either, because there are more accurate. I think we should say people in pain, but the accepted language and terminology in our field is either patients if they're receiving healthcare, or consumers if they're, and this is why I don't like it that much, if they're consuming healthcare. Customers that are buying healthcare off us. It just doesn't feel right to me, right? So if I go back to the phrase, I think many people in pain, and perhaps most, I don't know, in persistent pain, still get messages, and I think tend to believe that we, the health professionals and scientists, don't believe them. At the end of the day, we think it's not real pain, because we know scans show this or that, and it doesn't relate to pain, and we know that. And I get emails every week from someone who might have heard something I've said. There'll be someone responding to my talk today who will, I'm sure, think, so you're saying it's all in my head? And this is the biggest disappointment to me as a communicator, because I think the best we know of pain is that we would not have it if we had no brain. But we can definitely have it without the body part. However, all pain is like that. There's nothing different about persistent pain in that sense. And we have the immensely challenging task, I think, of simultaneously communicating, I completely believe you. And I am completely comfortable with the reality that your brain is producing this, because I see no exception to that rule in any human ever studied. But that's a really difficult message to get across when someone else has heard, when the receiver has heard a million times, oh, so you think you have pain. I know your pain's real for you. These sort of things. So they were data from back in the 90s, but I think a lot of them still apply, and we need to get better.
Do you think, so we've used these end organ model or pathophysiological models to explain why people have pain, and clearly we have data now to support that that's not the case, and you've just explained some of that. Is there a risk when we, so you previously used the phrase biologize to the patient, so use biology as a different science than anatomy to explain why they feel what they feel. Do you think there's a caveat in that as well? Could it be just the next thing that we are doing, and it turns out in a period of time that they do have the anatomy, but it's just not explaining their pain? Could it be that the nervous activation is not also explaining the pain? So I'm sort of alluding to the fact that we're not really sure of what consciousness is, but you used the phrase, it's the, what do you call it, the last organ?
The most proximal organ.
Most proximal organ.
Yeah. If I'm understanding the question properly, I would see there's two questions in there. And one is, we've gone away from this end organ structural pathology model. I think there is a very important caveat to us embracing a biopsychosocial, and I like to have a different phrase, a unified human approach. I think the evidence is very compelling that that's a good approach. It's the best approach we have at the moment. But the caveat to us saying it's not just about the end organ and structural pathology is that we say that. So in my understanding, which is incomplete, of pain, the sensory input is a big influence. And nociceptive data is a big influence. And when tissue is under threat or is inflamed, it makes sense for the brain to produce pain. And there are times when we can do something to that tissue that will stop the nociceptive input, and the brain now has no good reason to produce pain. So I think there is a caveat to that part of the question. And that caveat is, by embracing biopsychosociality, or the unified human, we're not rejecting really good decades, millennia of understanding the relationship between anatomy, nociception, load transfer, the physiological capacity of tissue to adapt and withstand stress and strain. All that's good stuff. My honours degree was in biomechanics and I loved it. And we should not reject it. But I think as compelling as the data saying, and we should not fall into the trap of mislabeling nociception or tissue data as pain, because it's, in my view, it's not pain. It's a piece of information.
Can I just try and just challenge you a little bit on this one?
Yeah.
So you give really compelling arguments why things are as they are, and I find it easy to sit down, relax, and listen to you, and really get convinced. And I agree with you. So you say things, and they seem so right. And I'm pretty sure that when I heard my first biomechanical explanation, it felt right as well. And then we would say the disc did it or the joint did it. So is it any different when we say now the bioplasticity did it?
Yeah, I think, and that's almost like the second part of your other question. Are we really just transferring the culprit? I actually do think. I put up a quote from a dude that I interviewed a long time ago who came out of this program saying, "Oh, I've got an injury in my dorsal horn now," and I think that is a significant trap, and I think we're falling into it. To say to people, "Oh, you've got persistent pain, you've got central sensitization syndrome," or "Now the problem is in the spinal cord," or maybe in your phrasing there, the problem is in your bioplasticity or your neuroplasticity. And this phrase that we use, again, based on a lot of research with consumers, patients, people in pain, this phrase that has a lot of resonance for people when they reflect on their recovery is this phrase, bioplasticity got you into this mess and bioplasticity can get you out. But by bioplasticity, I don't, in my mind, we never pitch that to the learner as central sensitization.
No.
We pitch central sensitization, the old version, before we updated it to allodynia and hyperalgesia for reasons somewhere in the nervous system. That's an example of adaptation and a shift in what happens to one cell when it's in a demand. That stimulus response profile, and it's part of it. But so is everything else that our system is changing.
Yeah,
in time.
But I'm really intrigued about. So it would be fair to say you're in the pain education business.
Yeah, right.
And I'm really intrigued about the fact that I really enjoy learning it as a professional, and we have data to support that when you talk to patients about their pain and you give them valid, current, or what do we call it, contemporary explanations that sort of fit their model, or the newer model, whatever they've read in the newest magazine they read when they were at the hairdresser, then that gives them a sense of understanding. And I struggle to find the exact time where the science becomes an explanation, becomes meaningful. And there's an emphasis, of course, because we're science driven, to say that the science shows this, so that seems true. And we believe firmly that this could be happening because we have data to support this could happen, and it could explain why I'm in pain. And we know there's definitely things in there we can't say for sure, but we are guessing. And I'm not suggesting anyway we shouldn't do that. I'm just curious about the fact, because isn't it really the patient we should be talking about? So what would we miss? Let me try and paraphrase it. What would we miss if we didn't biologize, if we didn't talk about bioplasticity, about central sensitization, and just looked in the patient's eye and said, you are really in pain, aren't you? I think I understand that.
Can I clarify the last bit? So you're still talking to the person in pain?
I'm talking to the person in pain now.
And I don't think these things are mutually exclusive. And I think more and more, I mean, one part of that talk today was me apologising because, and it was very authentic, because I completely underestimated what the difference between education and learning. and I think that's been a disservice to the field. I feel like I've been one of several players that have influenced the field of pain science education, and my influence has been suboptimal. But to go to your question, learning, who are the best teachers that we've ever encountered? They're the people who would sit down and say, you're really hurting, right? And I understand a bit about that, and we start exploring it. And it's an inactive journey, right? And the people who do learning for a living, well, I know they look at pain science education history and say, why did you ever expect that to work? And I guess I simultaneously feel embarrassed by that, my naivety and perhaps presumption that I was doing this thing clinically that felt like it had great results, and then I feel like I employed scientific method to test it, and I think we did, and I was naive to all this other stuff. But
isn't that just how everything is? You do your best, and
yeah,
you shouldn't
maybe
apologise because you've done your best all the way, but you are now wiser than you were before.
Yeah, possibly. I do think it's appropriate that I apologise, because I think because of my naivety, there are, and possibly, I mean, it's not meant to be a soul-searching session on Facebook, but possibly because of that combination of my naivety and maybe some of the things that you're observing, that I feel like I'm a decent communicator. There are now pockets of replicating my naivety, and I apologise that now that I was part of that, and I'm now trying to reverse that. But it's not soul-searching, Lorimer. No. But you've mentioned a few times about science, right? And I love humans, and I love science, and I think the scientific method is the best method we've got of pursuing truth, right? Whatever truth is, right? It's pretty iterative, I guess. But I think about, going back to your question about anatomy and bioplasticity, and is this just the next step? Will we look back in 5 years and think, actually, we got it wrong? Well, in a sense, I hope we do, because this is the other side of being a scientist that is just so liberating. We are obliged to get it wrong, and we are obliged to have theories, and we are obliged to prove them wrong and update them. So, look, I'm completely relaxed about realising, a big part of explaining pain 10 years ago was this message: we were wrong, but we thought we were right according to scientific method, and this is what the method tells us now. And it might be that we've gone from structural pathology, nociception is effectively pain, we now know that's wrong. At the moment, I really like the biopsychosocial unified human model, which in a sense is a model full of theories and predictions that we are systematically testing. And we seem to be getting data that support it, but that's not what science is meant to do. Science is meant to try and design the experiment that proves you're wrong, and then you move on. And that's an exciting part of being a scientist as well as a clinician.
So if I get you right, and this might be my bias, so please correct me if I'm wrong, but I hear you say that, so we can easily say we don't need anatomy or biomechanics to explain why people hurt. It's not the best science out there. There's another science, the neurosciences, collaterally, so many different sciences studying how does the body, physiology, biology relate to perception. And I think what I get from your talk is that we use this science, definitely as clinicians and as scientists, to develop new ideas and to test these ideas and hopefully to throw them out and to get new ideas and keep moving to really get closer to a truth. And we use the same knowledge, we use the same aha moments that we've had to help our patients to understand why we actually understand them. Would that be a fair way to understand what you've been saying?
Yeah, I think so. I think it's more a process of integration of scientific learnings than moving from one science to another. Like that, I think biomechanics, anatomy, tissue healing, it's all important data derived from scientific experiments, and we should integrate that into our decision making. But now we've got to start to integrate all that bioplasticity encompasses. And really, where we should be, integrating even better than we are, I think, is, well, how does the interrelationship of us with the world and the social determinants, and people in my research group are seeing that that's the untouched bit, and where people are going out into that. We've had workshops at this meeting about how to glia interact. I mean, this is highly reductionist, but it's still part of science.
It is, exactly. This might be a good chance to also slightly shift tracks here, because most of the people here would be studying a thing, glia cells or the periphery or whatever, and then using nociception as a means to generate pain if it's in humans, or using nociception to measure activity nociceptors in animals, and then do translational research perhaps.
Yeah.
But you're doing something slightly different. I know you're not the only one, but there are people like you doing another thing where you could use nociception, but you can also use different stuff. So in my mind, it seems like you're starting by the end organ, and then sort of trying to understand how does the integrated body relate to context. Is that fair to say?
Yeah. So if we were, if I was, applying for a grant, it says what sort of research do you do? I would describe my research group as travelling an iterative cyclical process where we do experiments on humans. So you would say that we do systems. We used to say systems neuroscience. Now I would just say human systems, because we can't seem to do anything to the nervous system without activating the other systems. But our experiments in the laboratory are all on live humans.
Can we dig into that for a second? So how do you go about studying humans? I mean, it sounds so obvious, but the scientific method describes certain rules. How do you apply them to whole body humans?
Yeah, well, it's a great question. It's a great question actually for non-scientists to almost get their head around. That someone will go up and we'll talk about an experiment. Let's say one of our experiments on a human. There is a massive amount of work that is done creating and preparing for that experiment. How do we go about it? Well, we identify what is the question, or in our research, what is the problem? That's a different way of looking at it. So one problem that we've identified in our interactions with clinicians, in our clinical encounters, we're talking with people in pain, talking with scientists, is the problem of evaluating something, the effect of something on a human by using pain threshold. Right?
So pain threshold is when someone has an experience of a stimulus like heat, cold, something, and they say, I can feel it as heat or cold or pressure. And threshold is when they say, now it's something else.
Now it's painful. Exactly. Now,
and that's an all or nothing point, isn't it?
Well, this is an example of how do we go about doing an experiment. So great researcher did a PhD in my group called Tori Madden, now working in Cape Town, outstanding researcher in person. She was looking at how well can we use classical conditioning.
Which
so
is
Pavlov's dog.
Yeah.
So by associating a noxious stimulus on the tissues with a certain cue, can we get to a situation where that cue alone shifts your pain threshold? That was the question.
Okay, so hang on. So you do something to me that is maybe 43 degrees of heat, and that is usually painful, and you do that at the same time as you wiggle the bell and flash the lights and show me something.
Yeah, so long as before we've wiggled the bell, flashed the lights, and delivered you a 50-degree stimulus.
Yeah.
Quite painful. So what we want your brain to do is to associate the wiggle the bell and the lights as highly dangerous, and we give you a marginally, it's on the margin of your pain threshold.
So it's enough to do nociception.
Yeah.
But it's not enough to give you big pain.
Well, this is the problem. So the problem is that and in my view now, there's no such thing as a conventional pain threshold. I just can't see one, right? And what we mean by pain threshold in the experimental community is what is the average temperature delivered to your skin, Morton's skin, in this laboratory by this person that is the lowest temperature at which you'll say that's painful. The problem is when we do that experiment, stimulus to stimulus, it's shifting by 2 or 3 degrees in the moment. So it's actually not a thing, right? So which, in my view, when we talk about pain threshold, we're really talking about what is the point at which everything that's going on that your brain is sampling makes your brain try to protect you. And the only stimulus we have control of is that temperature of your skin, right? But everything else is going up and down like a real life dynamic system that's doing all sorts of, there's inhibitory things, there's excitatory things, and so the problem we have is how do we look for a shift in the chances of having pain from classical conditioning in a human because we can't rely on pain threshold. So that's the problem. So then we have to devise an experiment that tries to get around that problem. And that involves a lot of discussion and a lot of pilot studies, which means we get volunteers in, we start doing things, and we think, okay.
I wonder if this would work. Let's try this one.
Exactly.
Oh, have you tried this one?
And the whole time you're thinking, our hypothesis is, so in that situation, our hypothesis is we can quantify a human system in terms of its likelihood to produce pain according to a curve that's generated by certain stimuli. That's our hypothesis. So then we do an experiment that will prove it wrong.
Curvy. Yeah.
Then we do a stimulus that hopefully will prove us wrong, and then we go on to the next experiment. So that might be a couple of months of pilot studies, then we get ethics approvals, and we go into the laboratory and we shoot people with little laser guns and we ask them what it feels like. Or we have electrodes around their skull that give us a readout of the brain's response to the stimulus. We record their temperature, their heart rate. So that's the way you do an experiment. And at the end of this 8 or 9 month process, you will tell the world about it via a manuscript. And that's one increment. So it's a bucket load of work.
It is, isn't it?
It really is. And for our research group, we've got those studies happening. And ultimately, all of those studies for us are trying to find solutions that might change pain in humans. So we first do it in healthy volunteers, and then if something looks promising, we start to do experiments in people who have pain. Still looks promising, we do what we call as a phase 1 clinical intervention. And if it still looks promising, we ask someone for a lot of money to do a randomized controlled trial. And if it comes out as efficacious, we then implement it in the clinic. And in the implementation process, we're looking for new problems. And the new problems come back into the lab and we start again. And that whole thing is 8 or 9 years.
Hence the slide that always comes last. We need more money for research.
Give us more money.
Yeah, so it's really a rigorous process, isn't it? And even if you went through all of it and you had an RCT, which is sort of almost top of the hierarchy, we tend to think that we need many of these studies and maybe a meta-analysis that say by now we have so many studies and they're pointing towards this, and then it's sort of something that seems reasonable, because if one lab does something and others can't find it, because there's a lot of things we don't know, even if we think we know what we're doing.
Yeah.
So it's always a body of evidence, and then to some extent you do something. It might be the first study that did it, like central sensitization, a really lovely study, 1983, published in Nature, and then then it just goes on, and it really has an impact, doesn't it?
Yeah.
And we try to become better at using it and applying it and understanding it, and it turns into maybe a principle or something that is almost generic. And I think this is how science works. It gives us good principles, but we also, by peer review and by natural skepticism, we try not to believe everything. So the more that points to one direction, the more safe we are when we tell the patients we think this is why you're hurting. Is that fair to say?
Yeah, I think a really accessible metaphor or comparison, if you like, for the shift in pain science over the last 30 or 40 years is the shift in climate science. That more and more experiments come in supporting the idea that humans are affecting the climate. That doesn't mean that we all change our behaviour, right? But I think it gives scientists the responsibility to effectively communicate, well, this is what the scientific method tells us to be true. There are occasional scientists who disagree with it, but I feel like this is an accessible thing for people outside of the pain field to say the difference between how we used to think about the climate and how we currently do is informed by the best method of pursuing truth that known to humankind. And all we can say is that method tells us this. How you behave is up to you. A fundamental difference between climate science and pain science is that I guess the bonus with pain science is what the science tells us gives people in pain potential solutions to their problems, whereas climate science gives us in the now problems. To us, we've got to curb our activity for some future.
I'm sure someone's working on solutions as well, but they're still in the process of doing the research, aren't they?
Yeah.
But that might be an excellent point where we can shift into the last sort of thing I really want to talk to you about, namely that you're not just doing, I'm not trying to patronize anything, you're not doing lab research only, and you're not just traveling around the world telling people about pain and then going home and counting the money. You're using that platform to generate, of course, money as well, but to generate interest and relevance of the things that you do in the lab and that everyone else is doing to inform patients. And then you actually do this thing called the pain revolution, which I'll have you talk about in a second. But where hopefully all of this comes together and really goes out to the consumer or the end user or the patient or the person living in pain. Would you care to talk about it for a minute?
I always love talking about pain revolution because it's such a privilege to be part of it. It really is, and I feel like in our research group we have this we have phrases that sort of do the rounds in the research group, and recently one of our phrases was do things that matter, and I really feel like pain revolution fits under that banner. What is pain revolution? So pain revolution is a range of activities, and the vision of pain revolution is that all Australians, we're focusing on Australia, although now other countries are looking to replicate some of those things, is that all Australians will have the knowledge themselves and the resources and the access to local support to prevent and overcome persistent pain. And that's the vision. And I guess the purpose of Pain Revolution is to turn around this massive societal and personal problem that we have with persistent pain. And
how you say we have? Is it a societal problem at all?
I think it is. I think it's very expensive.
So it's expensive?
I think it's very expensive. I mean, from a societal level, it's expensive. At a personal level, it's expensive, not just in lost income, but in suffering and in all that stuff. I mean, no one listening to this or watching this will need convincing that persistent pain is a drag. So, I mean, it's clearly to expand on that on the inquiry, the thing that has really struck me and led to the generation of Pain Revolution is that we actually know enough now to increase the chance that someone will receive high value care or not need care when they have an episode of acute pain.
Yeah, so you alluded to this in the plenary, and basically what you said, if I can paraphrase you on that, is that we've actually known what we need to know for quite some time, and we have the data to support, and we have the guidelines to suggest that we should be doing something else than studies suggest that we are doing.
Yeah.
And the barrier, why are we not doing what we say we should be doing?
Yeah, well, one of my PhD students, or ex-PhD students, Seamus Barker, writes really well on this, looking at the social problem and politico-social problem of persistent pain. There are so many players, I think, that make that barrier. But I don't have the view or the belief that we have discovered the best way to prevent and overcome persistent pain. But we've thought for 20 years, and the data have shown for at least 20 years and continue to show, that the best treatments and strategies we do have are education, active and psychological therapies, and self-management. They're the most effective things according to the peer-reviewed empirical data. And guidelines have been saying, let's do this for 20 years, and this is a point I made, but we're not. So the chance of someone receiving what I would call high-value care, high value because it's inexpensive relative to other types of care, it's more effective relative to other types of care, and it builds resilience and adaptation in the human for future episodes. They're all good things. But clinical guidelines clearly are not changing the likelihood that someone will receive that care. So Pain Revolution really is suggesting, let's get consumers to drive clinical practice change, because we're not driving it fast enough from the top down.
And what is the top? Is that science?
Well, from clinical guidelines, clinical guidelines and levers and funding streams and training. We're not doing it well enough. I think we should keep going there. But just imagine this scenario, and this is the utopian vision of Pain Revolution. Imagine the scenario that you as a clinician, someone comes in to see you with a painful back, and they expect and want high value care. Just imagine that. So you as a contemporary thinking clinician who thinks, I really want to give this person the skills and resources to master their scenario and to take on the recovery journey. And you know at the moment your first and most challenging job is to give them an understanding of why you're going to recommend the things that you want to recommend. Why you're not going to recommend low value care, because what they want is low value care. Imagine if they didn't want that anymore. Imagine if they knew, I've hurt my back, I am a bioplastic organism, so I will heal and I will recover. I'm going to hurt because pain is a really effective protective strategy, and I understand it. I'm going to go and see, in your case, a physio or me or the GP or the educator, the coach, and I'm just going to get the resources I need to manage this recovery. Imagine if that's what their expectations were. So that's the utopian vision, that we can drive clinical practice change when consumers want what the evidence has said for 20 years is the best thing we can offer them.
And can you tie that into the motto, which I think is, it's good, so learn about pain, it's good for you and your society.
Yeah.
I think I heard you say something like that.
Yeah, well that's one of our target concepts, which again are based on a lot of research. We ask people who have taken the recovery from persistent pain this question, what's the most important thing you learnt in your journey? And that comes out as one of those important things, and that being learning about pain is good for you and society. And that came out, and different versions of that are things like learning about pain is an intervention. Learning about pain is something you do as an individual. It's different to being given information.
And this might be the opportunity, because time is also running and stuff, but this might be the opportunity to give the question that I've been dying to give you. Explain pain. What is it really?
So that's from, I remember using this phrase so many times. How dangerous is it really? Well, explain pain is a book now, but it's
A working title?
It's what pain science education became in my language, based on Book with David and courses that they run and stuff. But if I was to replace, pain science education, what is it really? I think it is a moving beast. It's not a beast, it's a moving field that aims to give people an understanding that on the basis of which they will make decisions about their own life and care that fit with what the empirical data say are the best decisions to make. Have I answered that question?
I think that's great, and to some extent that would be what some people would call evidence-based practice. I know this is a weird term for some, but it's something we will have an interview with the man who coined that term tomorrow. So
yeah, cool.
We can have a go at that tomorrow. But it seems like it's really about integrating what we know to what patients know, so that we can communicate in a straight line, so that we don't have to do these twists and turns. And
yeah, right.
Well, metaphors is a way of communication, isn't it? But the minute we can talk, the minute we can sit down and they believe us and we believe them, and we can talk with trust and confidence that I know what you're all about, and they would say, I really think you know stuff.
Yeah.
Then therapy happens, isn't it?
Yeah, I want to respond to the metaphors because I love metaphors. I think in metaphors and I think they're powerful, but they're also not risk-free. Because metaphors are ways where I can give you an understanding of something that I know about, or I think I know about, in using an idea that we both know about. It's beautiful, it's lovely, right? Metaphor of ornithology hijacking Amazing Grace is a lovely metaphor of the system becoming overprotective, unless my presumptions about our shared knowledge are wrong.
Yeah.
And I think that's the risk, and that's why I feel like the learning science reminds us metaphors are really helpful and useful, but they're not sufficient. And they're not necessary, but they're really helpful. We have to also make sure, okay, let's explore that more. What's the content that will be useful, that you can operationalise in your decision making?
And do you see that metaphors are also used wrongly? Maybe just thrown out there, so they might be the so-called right metaphor, so they could be taken straight out of maybe Explain Pain, the book, and then used in different ways. Is that so? You were talking about your apology before, which I still don't think you should give. You've done your best.
Thanks.
But is that what you see, that things that is meant in a different way is used differently, or time has maybe surpassed it?
I just think we need to be careful, and we need to be respectful. Someone asked me the other day, so what's the most important thing in pain science education? And I'm sure they are after the golden nugget. But what I think is the most important thing is more about the relationship, and I think the most important thing is respect. I think if we talk in metaphor, we just need to do that in a way that is genuinely respectful of the resources of the learner and the experiences of the learner, and what that might sound like and feel like and mean from there. And I always think in sort of metaphors and visual metaphors, and I feel like in an education encounter, the deliverer should simultaneously be thinking, how can I be true and authentic to my knowledge base, but how can I also be with you, sit with you, almost like adopt you and hear myself. What does that sound like? If I've been told for 5 years just to get on with it, what does it sound like when I give this certain metaphor or think positive? What does that sound like? Anyway.
And in a good therapeutic relationship, you could ask the patient, couldn't you?
Yeah.
How does it sound like when I say that to you?
Yeah. What do you? And that's good learning, right? So, what do you feel when I say that? And you'll see it on their face. You might say something, and you'll see this look away, and you think, righto, there's a bit of dissonance.
Yeah.
And I think as an educator, we can respect that and say, so something happened for you then. Tell me what you reckon. I don't know. Anyway, I'm no expert on this, but I certainly find it exciting and full of possibility.
Yeah. Well, there's so many things we should discuss as well, but I find this might be a good place to sort of stop it.
Well, it's been fun chatting about it.
Yeah,
really
you too.
fun. Yeah.
Anything you want to add in?
Oh no, just to say, look, that we are so far away from knowing the truth, but we are not as far away from knowing the truth as we know it, if that makes sense. I think that we have an obligation to share what we know with humility and respect, and just keep up the drive to do this better. I don't know. That was my dodgy attempt at some sort of inspirational goodbye. Sorry for that.
We'll leave it at that. Thank you so much.
No worries, Morton. Thanks for having me.
Pleasure.
It was good fun.